very, very limited. And digital is really, really good for dense-breasted women, and those are the younger ones. So digital has come a long, long way, and right now I think that's pretty much standard of care for most facilities. Where are you going? Okay, and this is just, I wanted to bring an image of showing you what I do in my office, because when you come in for a mammogram, you don't see me. I'm kind of like Oz behind the curtain. I mean, you don't want to see me most of the time. But if you'll see here, this on the bottom is an actual digital mammogram, and it doesn't pick up really great on a slide. This would be something that we took today, and above it is the images we took a year ago or 3 years ago or whatever. So these are my comparison films up here. And actually what I did with this slide, I was trying to show the difference between, this was on film and we just scanned it into the computer versus a true digital image. Some of the main things you can see, this is the skin line out here. You can't see that up there. Or you never can see the skin. So there's a good probably inch or so tissue you never saw with the film image. And as you can see how much harder it is to see through that, it almost looks like concrete, it's so white. Versus here, there's some nice penetration and you can see some of the gray areas through the white. So it is a lot easier to read. And I purposely did this with more of a dense type breast to show you the difference of film versus the digital as well. And these buttons down here are the ones that I use to manipulate that image, to make it bigger or smaller or inverted or whatever I'm going to do. And this is just an up close and personal. This is a view of each side, and we label them left and right. And again, you can see skin real nicely. The white stuff in here is actually the breast tissue. The gray stuff is fat, which is very normal. Everybody has very different combinations of how much breast tissue they have versus how much fatty tissue they have. One's not better than the other. However, if you had all gray, all fatty tissue is the best to have because you can see everything. These are big images, so it'll take a minute. There it goes. And this is just the other view. That view is kind of an up and down look at the breast, and this is more of a side view of the breast, nipple here. And we look for some of these positioning things. See, this is your muscle. This is the pectoralis major muscle that's sitting right up there. And we want to make sure we get enough muscle down so we can see some of those lymph nodes that are hiding. There's some up here. Sometimes we can catch things like lymphoma, big, huge lymph nodes, and not necessarily breast cancer. I've found a few lymphomas. Or we can find, say, a metastatic cancer from the stomach or something like that. You'll have big lymph nodes. Most of the time when you find big lymph nodes, it's usually from breast cancer, though. Some of the new technologies that we have, I talked about a little bit about the breast MRI. I think that is one of the best technologies we have for diagnosing breast cancer. The drawback is it is so sensitive. I mean, we can pick up tiny, tiny cancers, but it also picks up tiny, tiny other stuff as well. So trying to go through a breast MRI is very cumbersome. Right now, what we're doing with breast MRI is mainly imaging women that were newly diagnosed with cancer. And the reason being is not necessarily to look at the cancer we know is there, is actually looking at the remainder of the breast tissue to make sure there's not another cancer in there. Looking at the lymph nodes into the arm to see if there's anything that looks abnormal, or even the lymph nodes that run along the sternum or your breastbone. Very, very good at doing that. Most of the time, before breast MRI came out, a lady would have her surgery, have the cancer taken out, which is called a lumpectomy. She does all of her radiation treatments, and about 3 years later, she gets a new cancer or a recurring cancer. Probably not. That cancer probably was there when she was diagnosed the first time. And it just takes that long for it to show itself. If we would have done her MRI and found that second cancer, she would have been treated appropriately and not have to go through the full ordeal twice. Just mentally and emotionally, it wreaks havoc on you. if you can imagine. But with the breast MRI, I think we're saving a lot of people. We're doing better surgeries on women now. I did an MRI, I think it was about a week ago, and found a lymph node right along the sternum because her cancer was up in that inner upper part of that breast, and instead of going here, it went to these. And these are never looked at during surgery. Surgeon doesn't go in, that's a major surgery, you have to go in and take these out. They don't get it with radiation. So see, she would have come back probably in a year or two with a big mass right here, and that would have been a recurring cancer. So we saved her life because we knew about it, the surgeon went in, they took out the lymph node, and now she's cancer-free. So some of these newer technologies are great as you use them sparingly right now. We also use MRI for high-risk patients, people with dense breast, and those are really the only things right now that insurance companies are paying for it. Let's see what else I have. This is your MRI. Look, I don't know, y'all probably all seen an MRI machine, I don't know if you have or not. I mean, this is just your typical MRI where you do a head, or you can do a shoulder MRI, or knees, or any of that kind of thing. This, however, is what we use for the breast. Here, one more head. And this is how you're positioned. It doesn't look very comfortable. If you can imagine someone that's 75 having to do this, you have to have a wonderful technologist that is very calming and very, I don't know, because you've got to stay very, very still in there. She's laying in here, and the breasts come through two holes on this, what we call a coil. It's almost like a mammogram in a way, but they just basically sit there, and you stay still, and they do the images. These are beautiful. So, and normally when I get to this point of doing a breast MRI, I'll bring the patient into my office, and we will review all of those images because they actually look like a breast. They don't look like an X-ray. They don't look like an ultrasound where you look at it and it looks like clouds floating everywhere. They actually look like something that you, as a non-physician, can look at and say, oh yeah, I get it, I see it, and you get a better understanding of all of that. Some of the future technologies, right now we do have PET scanning. I mean, that's very common, we use it all the time, but the newest technology is PET mammography. And it just got approved this last spring, and it's not being used very many places because there is problems with it. MRI we used to use at Scott and White when I was there, but we quit because we couldn't biopsy anything. We would find something on an MRI and it'd be like, now what do we do? And a lot of those ladies would end up with surgery that didn't need to be done. They would go in and remove a whole quadrant of the breast because we couldn't find it. Well, that's kind of the problem with the PET mammography, is you'll find a little spot and then you're like, okay, now what do we do? And I had one that came in from Dallas 3 weeks ago, and she had a PET mammogram with 2 4-millimeter areas in one breast. And they wanted me to do the MRI to see if I could find it. Well, we didn't find anything, so I told her, I said, go back to Dallas in 6 months and repeat that mammogram, the PET mammogram, and see what we can find. So with some of these newer technologies, we're still not there to be using them on, in everyday practice. This is just, it looks almost like an MRI machine. This is what a PET machine looks like. We didn't have one at the time to take a picture of, so, but we do now. Some of the other things that are coming out, what this is called is a tomosynthesis, breast tomosynthesis. And what it is, it's kind of like a mammogram machine, and in fact, it's an addition to the mammogram machine. You're putting compression just like you always are, unfortunately. But instead of one x-ray, it takes a series of x-rays through the breast, like a little fan. And you come up with all of these multiple images, and then it reconstructs, and it becomes a 3D image. So it's this x-ray, but yet you can turn it and flip it upside down and really see through the tissue versus, well, you know what I'm saying, kind of in through the ball versus on top of it. So I think this is going to be really great. In fact, this is still in beta testing, hopefully going to be out in the next year or so. I think they're working more on the radiation doses on that. And some of the real exciting research right now is on how to figure out who is predisposed to breast cancer. Right now, there's 2 breast cancer genes. One's called BRCA1 and BRCA2. Now, I've had several women that have had cancer in their 40s or their 30s who mom has breast cancer, sister has breast cancer, grandmother has ovarian cancer, and you know there's a gene. There has to be a gene. They do the test, and she's negative. And you think, oh my gosh. So there's obviously something else out there. Either another gene we haven't found, or something that triggers these cancers to actually take off, and we're predisposed with some other kind of gene that does that. So it's very, very interesting, and you know, instead of with your genetic testing, they used to have to draw blood and or bone marrow at one point in time. Now they can do it through saliva and urine, and it's much easier. Very expensive, but much easier.